moving on, and we are now on our third diagnostic group, the group of oncocytic and clear cell neoplasms. So the same lesions that sometimes look oncocytic, they can also look clear. And again, we have benign lesions and malignant lesions. Among the most common benign lesions, we have Wharton tumor, and one of the most common is adenoid cystic carcinoma, and they can be really challenging to differentiate, but we'll go over some interesting cases and discuss. And these lesions that I have put in parentheses, they can look either clear or oncocytic. Even basaloid lesions, if they have a predominance of oncocytic lesions, they can look like they belong to this group. So this is oncocytoma, and the key to diagnose oncocytoma is that if you find the very bland looking oncocytic cells and the clear background, no dirty background like in Wharton tumor, you have oncocytoma. This is a closer view, so the oncocytic cells have very low NC ratio, abundant oncocytic granular cytoplasm, finely granular cytoplasm. The nuclei are very uniform, small uniform nuclei. Nucleoli. On the Papa Nicolau stain, it's very nicely highlighting this very hypochromatic looking nuclei, very uniform, abundant granular cytoplasm. So comparing normal with oncocytoma, so normal parotid gland, you should see admixed fat, and you have this more organized architecture of a grape-like structure with some ducts, and you don't have fat inside the groups in oncocytoma, and you don't see ducts. So Wharton tumor, just to refresh your brain, the cells look identical to the cells in oncocytoma, and you have the lymphocytes in the background. Moving on to our fourth case, this is a 35-year-old woman, and she has a slow-growing and well-circumscribed parotid mass. So usually when we see well-circumscribed, we think, usually we are not wrong in thinking this is a benign neoplasm, but that's not always the case. On a low-power view, you have very cellular sample with three-dimensional groups of syncytial groups of cells. On a closer look, you see the cells have abundant oncocytic cytoplasm, some vessels, lots of naked nuclei in the background, but they are mostly very uniform, very monomorphic. A closer look here, you see the cells have a bit more like vacuolated cytoplasm, or coarsely vacuolated, somewhat also granular, but again the cells are very uniform. On the Papa Nicolau stain, this really looks very, very bland, no pleomorphism whatsoever. Lots of naked nuclei in the background and some vessels. And this is the cell block. So you will have here normal parotid gland on your left side. You can see small ducts. You can see the very organized grape-like architecture. And on your right side, you can clearly see that this is not normal. These are neoplastic cells. They have abundant pink to clear cytoplasm, somewhat granular. And I have the resection for you. So this tumor was very blue with lots of vacuoles. And you already imagine what tumor this is. So this is acinic cell carcinoma. Acinic cell carcinoma is usually low grade. It can be bilateral and is usually circumscribed and mobile, but it can occasionally be painful. On cytology, you tend to have very, very cellular smears. You have serous type looking cells with very bland nuclei. So a very common pitfall would be to think that this is benign or this is just non-neoplastic tissue. But the minute you start to see very crowded sheets of papillae, follicles, and clusters, and this abundant vacuolated, coarsely granular cytoplasm, no fat inside these groups, at least you should be really concerned that this is indeed a neoplastic process. So this is your differential diagnosis with normal salivary gland, benign lesions like oncocytoma, warthin tumor, other malignancies like mucoepidermoid carcinoma, sebaceous neoplasms, and we'll go over some of these differential diagnosis. So this is normal versus on your left side versus a case of adenoid cystic that was misdiagnosed on cytology. On cytology, it was thought to be a lymph node and with normal salivary gland tissue. So you can see here that in the normal salivary gland, you have fat inside these groups, whereas in neoplastic lesion here, you have no fat. But this case had lots of vacuoles, but these vacuoles are in the background, not inside the groups. And you have lots of naked tumor cells in the background. Acinic cell carcinoma versus oncocytoma, again, it can look very similar, but oncocytoma has more finely granular cytoplasm as opposed to coarsely granular and sometimes vacuolated in acinic cell carcinoma. But this feature can be very subtle and really hard to appreciate. So there are stains you can do, and as opposed to the stains in basaloid neoplasms, the stains for oncocytic neoplasms, they are very helpful, a lot more helpful than in the basaloid groups, because DOG1 is a very, very specific marker for acinic cell carcinoma in this setting, compared to warthin tumor and oncocytoma that are flat out DOG1 negative. Mucoepidermoid carcinoma can be faintly positive for DOG1, but it's going to be faint and focal compared to DOG1 that is strongly diffusely positive in acinic cell carcinoma. And P63 is going to show you the exact opposite immunoprofile. It's going to be dead negative in acinic cell carcinoma. It's going to be positive in this basal layer of warthin tumor, diffusely positive in oncocytoma, and mostly positive in mucoepidermoid carcinoma. There are other markers you can do, like SOX10 is going to stain similar to DOG1, strongly positive, diffusely positive in in acinic cell carcinoma, and negative in warthin tumor and mucoep. Sebaceous carcinoma versus acinic cell carcinoma, these two can be difficult to distinguish because sebaceous carcinoma also has very prominent vacuolated cytoplasm. On the diff-quick, sebaceous carcinoma can have a lot of lipid droplets in the background, very prominent vacuolated cytoplasm. There are stains you can do to differentiate sebaceous lesions from acinic cell carcinoma. If you have a good cell block, you can do AR and P63, and they're going to be strongly positive in sebaceous lesions and negative in acinic carcinoma. SOX10, opposite immunoprofile, negative in sebaceous carcinoma, positive in acinic cell carcinoma. But SOX10 is not very helpful if you're considering, let's say, an oncocytic pleomorphic adenoma, because oncocytic pleomorphic adenoma is positive for SOX10 in the myepithelial cells. Moving on to our fifth case, this is a 46-year-old woman, and she presented with a painless and slowly growing parotid mass. Upon aspiration, this lesion was partially cystic and did not regress. So that is a red flag when a lesion does not regress after aspiration. This was not a very cellular sample, but there were groups of cells with some degree of nuclear difference in sizes and shapes, so some pleomorphism, abundant oncocytic and somewhat vacuolated cytoplasm. On the diff-quick stain, you see very coarsely vacuolated cytoplasm with secretions. Some of the cells may make you think they are histiocytes, but if you look really close, there is too much cytologic atypia for you to mix this up with the histiocytic process or histiocytes. Again, more cytologic atypia, and this degree of cytologic atypia is, very concerning for a malignancy. There was a cell block, very scant, but I was able to do some stains. I performed a Mucin-Containing, and there was positive staining for Mucin-Containing. So I was initially worried, oh, could this be a mucoepidermoid carcinoma? However, the P63 was dead negative. So that is a little bit difficult to interpret if you're only able to do just a few stains. So what can we do about this case? You can sign it out as scant sample, suspicious for malignancy, and you can explain in your diagnosis that you're not able to further characterize this lesion, and you defer the final classification for the resected specimen. And this is the resection now. So you see this cell, this neoplasm with papillary architecture, some hobnailing with a ton of secretions and glandular structures, very pink-looking cytoplasm. So this was secretory carcinoma. Secretory carcinoma was formerly known as mammary analog secretory carcinoma. Like the breast tumor, it has the same rearrangement, the ETV6 rearrangements. It's characteristically strongly and diffusely positive for S100, negative DOG1 P63, and these stains can be extremely helpful to further characterize this lesion. Now, this is a very significant pitfall because these secretions sometimes they're positive for Mucin-Containing, and you might consider mucoep in your differential diagnosis if you find that. Comparing secretory carcinoma with acinic cell carcinoma, you can see that sometimes the morphology can look very similar, but again, if you have a good cell block and you can perform immunostains, you might be able to favor one over the other. As we move along, we have now reached our fourth group of the mucus-containing cysts. Among this group, we have benign, non-neoplastic, and neoplastic lesions. Like you have mucocele and you have a low-grade mucoepidermoid carcinoma. So here we see on this diff quick a ton of mucin in the background, but no cells. So mucin looks very somewhat bluish and dense in the diff quick stain. So the mucin-containing lesions, they tend to be paucicellular with a ton of mucin in the background. You can have histiocytes, you can have crystalloids, and some inflammatory cells. Now, the features that are going to favor a low-grade mucoepidermoid carcinoma is that whenever you aspirate the lesion and the lesion doesn't completely regress and you still have a residual mass, if you start to see higher cellularity and some cytologic atypia, with clusters of intermediate to epidermoid cells, then you should be worried you might be dealing with a low-grade mucoep. If you don't have cells and all you have is mucin, you should not report the sample as negative. You should report as atypical findings and put a note in your differential that both benign and low-grade malignant lesions are included in the differential diagnosis. And if this lesion persists or recurs, an excision should be considered. We are now moving on to our sixth case, and we have another parotid mass. And in this lesion, we have a ton of mucin in the background, this tigroid-looking mucin in the diff quick with some cells, somewhat bland-looking. And on this Papa Nicolau stain, you can see the cells have a higher degree of cytologic atypia, and you have frank necrosis in the background, more cytologic atypia. So now we're pretty sure we are dealing with a malignancy and more necrosis. Some of the cells, they look somewhat like mucoid or goblet-looking cells. Some have more clear cytoplasm. And in other groups, you see again a higher degree of cytologic atypia with very significant pleomorphism. Any considerations for this case? So we are pretty sure we are dealing with a malignancy, but anybody would guess what kind of malignancy? And yes, this is mucoepidermoid carcinoma. Mucoepidermoid carcinoma is the most common major and minor salivary gland malignancy, both in children and adults. It's characterized by the mammal tube rearrangements by fish that is diagnostic of mucoepidermoid carcinoma. Not 100% of them have these mammal tube rearrangements, but if you do find it, you can classify this lesion as mucoep, and that can be helpful in high-grade lesions. Low to intermediate looking lesions on cytology tend to be cystic and paucicellular, and in these cases many times the surgeon is going to perform a more modest surgical excision, but if you're able to say the lesion is very high grade, a more aggressive surgical excision will be performed with or without lymph node dissection. On cytology, these are the classic cells you can see with mucoepidermoid carcinoma. You can see mucoid cells. They're more common in low. You can in low-grade mucoepidermoid carcinoma. You can see squamoid cells. They tend to be more prominent in higher-grade non-keratinizing, and they're usually non-keratinizing. More predominant in high-grade mucoep. You can see clear cells. You can see intermediate cells. A ton of mucin in the background. But if it's overtly malignant, it can be really tough to classify the tumor as mucoepidermoid carcinoma on cytology. So here you see the intermediate cells. They're somewhat small and they look like metaplastic squamoid cells, mucin in the background, and here you have a higher degree of cytologic atypia. Here you see the mucoid cells, somewhat bland. So if you have all these features, you may be able to make this diagnosis with the mucin in the background, or mucoepidermoid carcinoma favor high grade. Moving on to our case number 7. This is a 65-year-old woman with a neck mass. Again, we had another sample that was very paucicellular. We had rare groups of cells with abundant oncocytic looking cytoplasm and some cytologic atypia. On the diff quick stain, you see some histiocytes, and you have again these bland looking cells with abundant oncocytic cytoplasm. And in some of the groups, you could see this dense pink matrix. What could this be? So I want you to notice that I did not say parotid, I said neck. And the neck is a very big place, so you can have metastasis, you can have all sorts of lesions. So I was able to do some immunostains, and this lesion was positive for PAX8 and TTF1. So this was a metastatic cystic PTC. So just remember, whenever you don't know where in the neck exactly you are, you should first try to find that out, look at the imaging, and if you're not very sure where you are, make sure you consider other lesions, not necessarily salivary gland lesions in your differential diagnosis. Case number 8. This is a 70-year-old male, and he has a rapidly enlarging neck mass. So on the diff quick stain, you have the cells forming this cribriform architecture, and the papanicular stain, you have some papillary looking structures, and you can see the cells have abundant oncocytic cytoplasm, but they have a high degree of pleomorphism, very prominent nucleoli, mitotic figures, and I have some close-up. You see more mitosis, some vacuoles, very prominent large nucleoli, necrosis in the background, very high degree of pleomorphism, some binucleation. So what could this be? So we are now in the differential diagnosis of high-grade malignancies. So in this group of high-grade malignancies, you can have primary and metastasis, but among this group, even inside the parotid, metastasis is more common than primary lesions. And among the primary lesions, again, you can subdivide the lesions among pleomorphic oncocytic and pleomorphic basaloid neoplasms. And the lesion we were just discussing was a pleomorphic oncocytic neoplasm. And among primary lesions that can look oncocytic in the salivary gland, you have salivary duct carcinoma, carcinoma XPA, high-grade mucoep, adenocarcinoma NOS, oncocytic carcinoma, and of course any metastatic carcinoma can look like that, metastatic adenocarcinoma, melanoma, so very important to correlate clinically. So these are the stains I was able to perform, and I was able to prove this lesion was positive for AR, GCDFP, negative P63, and DOG1. So this tells us that we are probably dealing with salivary duct carcinoma. Salivary duct is very rare, it's more common in elderly men. It usually looks overtly malignant, and here you have the corresponding resection. It somewhat looks like breast ductal cancer. You have this cribriform architecture with bridges and very characteristic immunohistochemical staining profile. You have positive for AR, GATA3, negative P63. And if you're able to determine that this tumor shows HER2 gene amplification, the clinical team might be interested in using trastuzumab therapy. And this is especially important in the setting of unresectable lesions. Comparing with metastatic squamous cell carcinoma, if you don't have a whole lot of keratinization, it can be difficult to distinguish these two, but here in the background, in this case, there are some cells with a bit more keratinizing cytoplasm, but the immunohistochemical staining profile is going to be very helpful since it stains exact opposite as salivary duct carcinoma. Salivary duct versus high-grade MEC or mucoepidermoid carcinoma, again by morphology can be a little difficult, but the immunostaining profile is helpful since salivary duct is AR positive P63 negative, and mucoep stains like squamous cancer is positive P63 negative for AR. This is our final case. This is a 26-year-old Asian woman, and she had a 4.1 cm parotid mass and enlarged neck lymph nodes. And that's all the information I had for this case. So you can see on the diff quick stain the cells of high-grade pleomorphic basaloid scant cytoplasm, and on the Papa Nicolau stain they have very coarse chromatin, somewhat molding, and different kind of shapes, pointy edges, and scant cytoplasm. On the core biopsy, here you see again the neoplasm, very pleomorphic basaloid with some admixed lymphoid cells. So this is our differential diagnosis. You could have a high-grade transformation of any salivary gland, could look like that. You could have a primary lymphoepithelial carcinoma of the parotid gland. And very important that most commonly when we are dealing with pleomorphic lesions, metastasis is more common. And with that look, you might be tricked into thinking you have a metastatic non-keratinizing squamous cancer or nasopharyngeal carcinoma, oropharyngeal carcinoma, non-keratinizing HPV related can have that same morphology. You can have a metastatic cutaneous malignancy like Merkel cell carcinoma. So very important to correlate clinically to choose your immunohistochemical staining panel very wisely. Just to highlight here that adenoid cystic and acinic cell carcinoma, once they have high-grade transformation, they can look pretty similar, even though one belongs to basaloid group and the other to the oncocytic group. But once you have high-grade transformation, they all have high NC ratios, and on morphology, this distinction is going to be very hard. So going back to our case, I was able to do some stains. Our tumor cells were strongly and diffusely positive for P63. There was no other cellular population. The background was lymphoid. There was no MYB staining for adenoid cystic. There was no DOG1 staining for, let's say, a high-grade transformation of Acinic. There was no neuroendocrine marker for Merkel cell, no CK20. There was no P16 for, let's say, a metastatic oropharyngeal carcinoma, but strongly diffusely positive P63 indicating squamoid differentiation. And with the sprinkled lymphoid cells, with that morphology, I decided to perform EBV in Situ Hybridization. EBV Situ Hybridization was strongly and diffusely positive. So is that a metastatic nasopharyngeal carcinoma to the neck? Could that be? So that was the initial consideration. But this case was signed out as a non-keratinizing carcinoma with a comment stating that in the absence of a distant primary such as the nasopharynx, this tumor could represent a primary parotid gland tumor or lymphoepithelial carcinoma of primary of the parotid could look like that. So lymphoepithelial carcinoma, primary of the parotid, extremely rare tumor, but it's going to stain, it can stain identical to the nasopharyngeal primary, including the positive EBV, but often in Western countries it can be EBV negative. But that's a very significant pitfall as the staining profile can be identical. So it's extremely important to know whether you have a nasopharyngeal mass or not. And if you don't, then you might be dealing with a primary lymphoepithelial carcinoma of the parotid gland. So we're finishing up this didactic lecture. I just wanted to point out that precise classification is not possible for all lesions. If you don't have all features, you might be better off using the Milan system, describing that when you're sure you're dealing with a neoplasm and providing the differential diagnosis. For example, basaloid neoplasm, differential includes basal cell adenoma, pleomorphic adenoma, and adenoid cystic carcinoma, and only by doing that is going to be very helpful, since you're going to be able to guide clinical management and maybe the extent of surgery. And very important, especially in the high-grade lesions, is that you correlate clinically to make sure you consider the possibility of metastasis. And this is all I have. Thank you very much for your attention.